Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 126th episode of the CodeCast podcast today. Happy St. Patrick's Day. I am 68.8% Irish, according to 23andMe and Ancestry.com, so I love this day. My mom was actually from Limerick, Ireland, and 100% Irish. So again, a great day. I love St. Patrick's Day. So today, I'd hate to tell you this, but yes, I am going to talk about COVID-19. I'm hoping it's the last episode I actually have to talk about it for a while, because like you, I know it's just flooded the airwaves. But my topic is going to be from a reimbursement perspective and some of the misinformation that's out there. There's so much information that's not accurate. It's actually frustrating me. All I keep seeing are these clickbait titles of COVID-19, and then I read it and I'm just like, oh my gosh, that is not accurate. So I wanted to present some FAQs, which I will also put on my blog on my website at terryfletcher.net, because some of the misinformation could really cost you and your patients a ton of money. First of all, the patients and out-of-pocket expenses, and then not to mention the physician practice, because you're going to be dealing with possibly denials and then patients not wanting to pay for the denial. So then when no one is paid and your patient's not happy, it's a lose-lose situation. So we want to get the FAQs, which are the facts, straight. And I've been researching, confirming, contacting 6 to 10 hours a day on this topic, have a pipeline into Medicare and also AMA. And I've been picking apart a lot of the things that we've been hearing from the president on the airwaves as well. And so hopefully, and we know that we have as much accuracy as we can, but hopefully this will give you some insight as to what is accurate, what you can do now, what we're still waiting on, because there's some things that we're still waiting on. And you'll need to wait as well. And you want to make sure that even an informed discussion with your patient doesn't mean that you have the black and white answer. It means you'll have to say, we're waiting to hear. So before we get started, today the CodeCast podcast is also brought to you by Keck Medicine of USC, over 500 internationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, Los Angeles, California. Okay, so let's take a look at these FAQs surrounding the COVID, which is the coronavirus 19. It also will involve some telemedicine, because I know that's been a big topic on the airwaves and on social media, etc. But one of the things that have come up is regarding, will Medicare pay for an e-visit between a physician in an office and the patient at home, billed with the E&M codes 99201 to 99215. Those are new and established patients. Well, what we've been told is that this could happen soon. Temporary measures are coming in, and they're temporary, and I'm hoping to have details by next Monday. But a bill passed that will remove restrictions for telehealth for the original Medicare patients. So the patient won't have to be from an underserved area anymore, and they'll no longer have to go to an originating site, so they will be eligible to be seen at home. There has to be a video via phone or patient portal that will be allowed, but it has to be HIPAA protected. So there's still some things there that may or may not be appropriate. The MGMA also wrote to CMS and asked when we'd see these new guidelines, and CMS said that early next week, and that's the week of March 16th. So check back next week on my blog. I'm hoping to have an article up to give you the information for that to make sure you're clear. But right now, it is not covered, and you would see a denial unless you're in an underserved area. Medicare sent out a COVID-19 update also March 8th, and they did announce that they're only paying for certain codes that have to do with telehealth. Now, I'd mentioned some of this last week, but I just want to make sure that you're understanding what it is, because everybody's starting to bill for some things. I even have my clients out there saying, oh, we've sent this sheet up to the doctors and sent it to them before I saw it. And I'm like, oh my gosh, please tell them that that's inaccurate. Get it back. Because you have to be careful with the fine print. So the virtual check-in code, which is worth about $15, that's the G2012 code. That code Medicare put out 2 years ago saying that a patient could initiate a call to your office from their house and basically say, do I need to come in because I have these symptoms? But the patient cannot have been seen within the last 7 days for any problem, not just related. And the patient, and then if you talk to them on the phone, meaning one of the clinicians, one of the clinical team people, and there's a physician in clinic, then let's say that they have symptoms that lead you to believe that they need to have a coronavirus testing kit done. Well, if you have them come in within 7 days or the next available, you can't charge for that visit. The virtual check-in means that you didn't need to see them. You could just handle it over the phone. There's also the new 2020 codes. I did a big podcast on this a couple of weeks ago, and those are the digital assessment codes where the patient accesses the physician. Both of these are patient initiated, by the way. But these are when it's just through the patient portal. And again, you've got a 7-day global on that. But none of those codes describe an office visit between the patient at home and the physician, nurse practitioner, or PA in the office. So make sure you are not coding office visits, new or established, for phone calls. You can't do it right now. And this is as of the 17th of March. Now, I also keep hearing about payers who are encouraging telemedicine, and these are commercial plans. Is this true? Well, some insurance companies have a service for virtual e-visits, or they call them MVP visits or VIP visits. I actually have it on my insurance, and I have Anthem Blue Cross, and this is for insured individuals. But they use a third-party service to provide these visits. They don't let me see my own physician if I need to. So I have to call in, and then they direct me to another call that I have to make to see one of these virtual physicians. And so be aware of that. It's not to the patient's own physician. It's a virtual physician that's on a panel with these payers. So that's pretty important to understand. Okay, so there was a new law that was passed on, and this is the one I was telling you about. This is the HR 6074, and that's what you're looking for, that eases restrictions on telehealth. But CMS has not updated its policies on that, and that's what we're expecting on the 16th, or at least the week of the 16th of March next week. And so you always want to understand, when it passed on March 5th, it still wasn't implemented yet. And because this is uncharted territory, we're trying to find out if we're supposed to bill with place of service 02. That's the telemedicine place of service. Are we supposed to use the modifier 95? Because right now, if you try to do that, it'll be denied. And so you have to be mindful of the fact that it's coming, but it doesn't mean that it's perfect yet. And you have to be careful with that. So another thing that did come into effect, and this is actually a good thing. So there was something that was passed on Friday, and that was actually the 13th. So it was Friday the 13th, which obviously should make you a little scary. Just kidding. But there was something that was passed with regard to test for the coronavirus. So there's a new CPT code. It's on the AMA website, and it is effective as of March 13th. And this is CPT code 87635, and that's for infectious agent detection by nucleic acid and nDNA or RNA, severe acute respiratory syndrome, coronavirus 2, that's the SARS-CoV-2, the coronavirus disease, COVID-19, the amplified probe technique. So that's what that's for. That's what they're looking for. The 87635 will help to efficiently report and track testing services related to the SARS-CoV-2 and will streamline the reporting and reimbursement for the code. And again, that is available on March 13th, which is last Friday. Make sure that you're uploading that code and descriptor into your EMR and EHR. And make sure you look at the CPT and AMA press release for that, because they also have charging guidelines based on your geographic location. So you need to look at their website to make sure that you're clear on all of that. Now, another thing I wanted to bring to your attention, and this has to do with the financial well-being of your patient through this whole debacle of the COVID-19. I really believe, I'm not trying to minimize the disease and people that have died or are infected or have had the problem. I think there's people out there that didn't get diagnosed when they had it because they had an upper respiratory infection, and it really wasn't on the forefront until we started seeing people in other country dying from it and how severe it was. So we just don't know a lot of things still, but I think you have to be careful when you're looking at some of these things. Just telemedicine's a good example, because I think the patient's financial well-being as well as their physical health could be, affected, because the Centers for Disease Control, even though they're not billing for the coronavirus testing per se, and because of swift government action, many of the COVID-19 testing performed by independent practices or hospitals, so the lab test part, most of that won't come with a share of cost for the patient, but the patients still have to be aware of some of the hidden cost that they'll most likely be on the hook for that isn't going to be subject to some of this government relief and some of the possibility of waivers by the payers. So think about this. What about an emergency room or urgent care charge? If the patient contracts the virus or severe symptoms warranting an out-of-network emergency room visit, maybe they're not close to home or close to where maybe they're a Kaiser patient or something like that, then procedures related to coronavirus testing and treatment, that could range anywhere from $350 to over $1,200. And I found that amount from Modern Healthcare. Also remember that deductibles for private and commercial insurance has risen almost 500% in the past few years because of what happened with the Obamacare insurance exchanges that forced Americans to become insured. The current average annual deductible for Americans who get health insurance on their own is $5,500, while people who are offered plans through their employer is around $1,500. Since the coronavirus is spreading early in the year, many workers may have not hit their deductible yet. We're still in the first quarter. And so Americans may also be affected by surprise billing. And what that is, this occurs when a patient receives care at an in-network facility, but receives a higher bill than expected because a physician who treated them or handled their tests may be out of network. Surprise billing hits 1 in 6 emergency room or hospital patients, and I found that in Becker's Hospital Review. That is a huge number. And remember, surprise billing legislation, that only relates to the facility charge, not the physician's fee. So if a bill from an out-of-network physician shows up at some point to the patient, that's their financial responsibility for that share of cost. Also, in a recent AMA survey, it suggested that more than 25% of U.S. adults have delayed getting medical care for financial reasons. I had a friend where I live, and so she was a California resident, and she was charged $4,100 for coronavirus-related testing and treatment in early February. She received a bill that included charges of about $2,440 for virus and flu testing, $1,050 for her ER visit, and about another $610 or so for miscellaneous hospital and also her physician's bill. Since she's a healthy person, she had not met her deductible this year. And then 21 days later, when she received the bill from the hospital, she knows that her out-of-pocket now is going to be $2,300. She will have no government or insurance company relief because it was determined that she only had an upper respiratory infection and allergies, and she wasn't positive for coronavirus, which is the positive, but from a financial standpoint, suspected coronavirus patients do not have any recourse to offset the expense of the testing, even though when she called the ER and explained her symptoms, and she was told to come in immediately for testing. And so she still may be getting another bill from the physician's office, she said. She's not sure. And then possibly the lab. And, as a healthcare professional, the reason I bring this to your attention, you need to be mindful of all the information that's currently being posted out there on financial relief for patients for the coronavirus pandemic. There is a lot of misinformation, and what's happening is that it's not accurate on how any money will be funneled to patients who should see or will see large out-of-pocket expenses due to testing, hospital visits and stays, and physician charges. There's not yet been a clear point A to point B guide to know who will get the relief and who will not get the relief. And there's a lot of people out there, like I said, that are testing thinking they could have it, They end up not having it. They're not a celebrity. And so they don't have the funds to be able to offset those charges. And so before you have a financial conversation with the patient on what their share of cost will be, make sure it's accurate, informed, and in writing. Because the one thing that when I was listening to all of this relief and everything that's happening in the news regarding, patients will be taken care of and blah, blah, blah. The one thing that I kept thinking of in this is, let's say a patient does have a $2,000 or $3,000 deductible, and they say, we're working with insurance payers so that they waive those. The patient doesn't have the deductible, so they're waived. Okay, well, who pays the doctor? Remember, that's the first part of what's the patient pays before the doctor then is paid from an insurance perspective. Well, if they're waiving that doesn't mean that the payer is going to come in and pay it. They're just saying they agree to not get the doctor in trouble for waiving the copay or deductible. And a lot of the payers are saying we're not really agreeing to that. We said we take it under advisement. We've already seen Blue Cross and Blue Shield of Michigan say, yeah, no, we're not doing that. So there's just a lot of different aspects to all of this, and you again want to be accurate and informed. So we're trying to give you the most up-to-date information possible so that you aren't out there kind of trying to figure out what to say to a patient. So again, just keep looking at my blog on my website, keep listening to the podcast, and we will make sure that you have what you need to be informed and give information to your patient that's accurate. Okay, so let's look at my coding question today. And this one comes from one of my California subscribers. And it says, Terry, the cardiologist introduced a catheter into the patient's common femoral artery and advanced it into his aorta and performed an abdominal aortogram. Then the cardiologist removed the catheter. What should I report for this? I'm just lost. Okay, so you have the 36200. That's the introduction of the catheter, and it's stuck in the aorta, so that's where it's placed. And then now you have a radiology code for this service, 75625. It says aortography, so that's an image from the aorta. It says abdominal by serialography, so that means it's an abdominal aorta, and serialography means multiple views. Radiological supervision interpretation. When you inject into something that's not the coronary, you go to the radiology section, and the imaging is also the injection code. So it's the example of what we call a non-selective catheterization with an injection. The catheter directly goes into the desired blood vessel or organ. There's no manipulation of the catheter because the physician does not advance the catheter into other branches off that vascular family or off that aorta. And then they basically inject where they are and let the dye run down or up if they're above the vena cava, and then they remove it and they check out and see what they want to see on those films. So just know 36200, 75625, and if this is done in the hospital setting, then you're going to need a 26 modifier because you're billing the professional component on the 70,000 code. Our coding question is brought to you today by Stratus Building Solutions, leading the way in health and environmentally conscious commercial cleaning services, green clean chemicals, green clean certified, biodegradable, and non-toxic chemicals, providing a healthier environment for your customers, patients, and employees. Protect your practice today. stratusbuildingsolutions.com. Okay, my personal insight this week, I promised you I can't help it. I'm on a bandwagon with this coronavirus nonsense. And I know some of you think I'm being flip about this. I'm not. I'm just seeing the hysteria, and I'm just like, what the heck is going on with toilet paper? Okay, I have to ask that question. Since the coronavirus started, there are lines around Costco and Sam's Club around the country with people buying hundreds of rolls of toilet paper. Okay, what the heck? We're not heading towards an apocalypse. We don't have tornadoes or hurricanes in California or anywhere that is impacted right now in the country. Restaurants, for the most part, are still open. Gas prices are the lowest they've been in 10 years because Saudi Arabia and Russia can't seem to agree on oil barrel pricing profits. I understand that this is flu season. Coronavirus is scary. But for those of us that have lived through the swine flu crisis, H1N1, SARS, all of that, there's hysteria and madness out there when everyone just needs to take a breath. We have closings of schools and colleges, and all professional sports have shut down. And college sports are shut down. And what's interesting about that is everyone's supposed to self-quarantine. Well, have you looked at New Orleans or New York Times Square or clubs in Los Angeles or how they're doing in Miami? The college kids are having a good old time. They're out there partying. New Orleans said that they didn't even have enough staff to deal with the impact the bars have had over the last 3 days. Everyone's gone wild. So everyone, just please take a breath. Hoarding toilet paper is not the answer to the problem. But if you need a roll, my box of 48 from Amazon arrived yesterday. I mean, if everyone's buying it up, I might as well get some, just saying. Anyway, everyone today, thanks for listening. I promise the next episode will hopefully be coronavirus free and more positive, and we'll move on to more information in the healthcare industry. But on this Terry Tuesday, make it a great day and hopefully a great week. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.